Welcome to Neuro and Rehab for PTAs. Chapter 1 of this textbook talks about the roles of the physical therapist and the physical therapist assistants in neurologic rehab. So, I would take some time to review the Nagy disablement model, looking at how that kind of created the foundations for us to build the ICF. We look at impairments, which then help us determine functional limitations, which with the ICF we refer to as activity restrictions and participation limitations. And the overall disability being in the context of the person's ability to function within their world. It's important that when we look at disability, we look at that as being the result of when functional limitations become so great that the person is unable to meet age-specific expectations within the social and physical environment. And so that means we're going to have different considerations for what we expect somebody to be able to do at 6 months versus 6 years versus 16 years versus 60 years versus 90 years. And so disability is often going to be contingent upon age. So we can look at how those things working together with disease being related to the pathology and then the impairments being related to the alteration of structure and function. Our functional limitation has difficulty performing routine tasks, disability being a significant functional limitation and cannot perform the expected tasks, and then handicap having a societal disadvantage of disability. The ICF model grew from there, and we've kind of hit on this enough times that you guys should be able to understand what these are, knowing the difference between activity limitations being specific to the household and participation restrictions being within the community and those social roles. Review these things at your leisure. So the PTA provides interventions, and we know that this happens under the supervision of the physical therapist, depending on the insurance type and the setting type. That's going to be either direct or indirect. But either way, PTs must supervise the PTAs. Therapists should consult the APTA and the State Practice Act for specific documentation and supervision requirements, because those are going to be different for neuro populations based on the settings that they're being treated in and based on the insurance coverage that they have. And so you're going to look to refer to APTA and your State Practice Act for what falls within the scope of care for what's being delegated to the PTA, and also what documentation requirements are going to be needed. When the PT is evaluating a patient with a neurologic condition, they need to critically examine the patient for stability, acuity, criticality, and complexity. Members of the healthcare team are going to include the family and the patient, who are going to be the most important members of the healthcare team. The patient and the patient's goals have to be the primary focus of the recovery process. Otherwise, you're not going to get that patient buy-in that's essential for patient recovery. We also have the PT and the PTA, the medical doctor, the nurse, the OT/OTA team, speech therapist, and the child's teacher when we're looking at pediatric populations. Chapter 1, fortunately, was a pretty easy review of things that we've talked about and basically the role of the PTA, and so quick and easy to get through. As we move on to Chapter 2, we're going to look into a review of the neuroanatomy. We've touched on these things a little bit, but we're going to dive a little bit deeper into the structures of the central nervous system and what they do and what deficits occur as a result of injury to those. So when we look at the nervous system, it has to manage the entire body. It's got to be able to reliably communicate with the whole body, but also be flexible enough to change over time and learn to solve problems. So our peripheral nervous system manages that reliability, and it has a limited adaptability, whereas our central nervous system, our central nervous system has more of that flexibility. And so our central nervous system has the neuroplasticity developments that happen so that we can adapt when there's a deficit. So we look at the components of our nervous system. We have our overall nervous system, which breaks down to our peripheral and our central nervous system. And our central nervous system is going to be made up of our brain and spinal cord. Looking further into the periphery, we know it breaks down into our autonomic and our somatic nervous system. So our somatic nervous system is going to control external actions of the skin and muscles, and that's what we have voluntary control over. Our autonomic nervous system, we do not have voluntary control over, and that controls the internal activities of organs and glands. And that will break down to our sympathetic and our parasympathetic. Remember, our sympathetic is our fight or flight, and our parasympathetic is when we are relaxed. Looking at cells of the nervous system. So neurons are typical cells of the nervous system, and they are specialized for communication through their ability to generate rapid electrochemical signals. Neuroglia are the diverse support cells that facilitate neuron function and survival. And we've got several different types of neuroglia, and you are going to want to be familiar with these. So our astrocytes provide a vascular link to neurons, contribute to the metabolism of the central nervous system. They regulate extracellular concentration of ions and neurotransmitters, and they proliferate after injury to create a glial scar. Our oligodendrocytes are the ones that myelinate the axons of the central nervous system, and so they are super important for helping the nervous system maintain conduction speeds. Patients who are diagnosed with multiple sclerosis often have degradation of the oligodendrocytes, so their axons can't be remyelinated, and that is how conduction speed slows in patients with multiple sclerosis. Our non-myelinating oligodendrocytes appear to regulate ion concentrations. There's not a substantial amount of research about exactly what they do other than the ion concentration regulation, but we do know that there is a difference in their function because they do not myelinate. Microglia engulf and digest pathogens and assist the nervous system with repair after injury. Our ependymal cells line the ventricular system and produce and circulate our cerebrospinal fluid. And then the peripheral nervous system neuroglia, we have satellite cells which buffer extracellular ion concentrations. And we have Schwann cells, and we've got a couple different types of Schwann cells. So we've got our myelinating, which help to myelinate axons in the peripheral nervous system. So our oligodendrocytes are for the central nervous system. Our myelinating Schwann cells are for the peripheral nervous system. Our non-myelinating Schwann cells function similar to the astrocytes of the central nervous system, providing vasculature and participation in ion buffering. And then we have terminal Schwann cells, which help to maintain the neuromuscular junction where the neuron communicates with the muscle. So when we look at a neuron, it is broken down into several different parts, and I would take a look in your textbook at the picture that labels those parts, and I would familiarize yourself with that picture pretty clearly. We look at the dendrite, and that is the part sticking off of the cell body that helps to receive information. So it takes extracellular input and creates an intracellular signal, most commonly producing electrical currents, which are then transferred to the cell body for processing. So we can have dendrites that are unipolar, pseudo-unipolar, which means that they have no true dendrite. We can have bipolar neurons, which have a single dendrite because there's going to be from the cell body one protrusion for the dendrite and one protrusion for the axon, making it bipolar from the cell body. And then multipolar neurons have multiple dendrites. The cell body is the main part of the neuron, and that's where the nucleus is going to lie. And it's responsible for synthesizing proteins, supporting functional activities of the neuron, such as transmitting electrochemical impulses and repairing cells. The cell bodies with similar functions are often grouped together to form nuclei in the central nervous system and ganglia in the peripheral nervous system. And so their dendrites will all extend from this grouping of cell bodies, and their axons will all extend from this grouping of cell bodies. And it helps to strengthen the nervous system. And then the axon is what transmits that signal from the cell body out to its destination. Action potentials are carried down the axon to stimulate the release of neurotransmitters. Axons can be myelinated or unmyelinated. Signals that are traveling on a myelinated axon are going to travel faster than signals that are traveling on an unmyelinated axon. So that figure that I said to be familiar with is figure 2-3 in your book, and be able to label the parts of a neuron. So we look at upper motor neuron disorders versus lower motor neuron disorders, and we've talked about this a little bit, so it should be a review. But when we have upper motor neuron damage, that's typically happening in the cortex with the neurotransmitter glutamate involved in response to the injury. It is targeted to the central nervous system, and symptoms present with spasticity. So we see an increase in reflexes, an increase in tone, an increase in spasticity, decrease in atrophy because the muscles are constantly contracting. We do have increased weakness. So just because a muscle is spastic and has increased tone doesn't mean that it's going to be a strong muscle. And so that's important to note. And it's also important to note that with upper motor neuron lesions, we're not going to see fasciculations, which are those small muscle twitches. Lower motor neuron lesions, however, typically are going to happen in the brainstem and spinal cord, and the neurotransmitter involved with those is going to be acetylcholine, happening outside the central nervous system. And symptoms typically present with a paralysis. So we see decreased reflexes, decreased tone. We do again see the increased weakness, and we're going to see atrophy in these patients because they don't have the spastic tone that's promoting the muscle staying the same size. So upper, we see an increase in tone, lower, we see a decrease in tone. Myelin is the white fatty substance that surrounds axons and helps to speed up conduction speed, because the myelin doesn't go the entire length of the axon. There's little blobs of myelin with gaps called the nodes of Ranvier, and the signal basically gets to skip over the parts of the axon that are myelinated, and it jumps in between the nodes of Ranvier. So it increases the efficiency of action potentials by increasing the conduction velocity and decreasing the metabolic expenditure. So instead of having to generate energy to push the signal down the entire length of the axon, it can skip these lengths and not require as much ATP. Myelin in the central nervous system is more compact and it prevents axon regrowth. Myelin in the peripheral nervous system is less compact and allows for axon regrowth. Demyelinated neurons must continue to spend higher amounts of ATP for each action potential, leading to the production of free radicals, which damage macromolecules and are generally toxic to cells. And so this is part of that cycle that we talked about when patients have demyelination as a result of damage to the oligodendrocytes with MS. MS is a neurodegenerative disorder, and it's caused by an autoimmune destruction of the oligodendrocytes that causes that demyelination, and then there's more energy expenditure needed to transmit any signal, and so the signal becomes weaker, and that plays into part of the relapsing remitting presentation, but is also a big component as to why patients with MS are so fatigue intolerant. So our central nervous system and peripheral nervous system communicate via the use of neurotransmitters. And I would make sure that you know the function of these neurotransmitters to understand what they cause when they're released in the body and maybe to pass your exam. So we've got acetylcholine, which conveys information to the peripheral nervous system and is used by lower motor neurons to synapse onto skeletal muscle fibers. It also helps to regulate heart rate and other autonomic functions, but acetylcholine is really important in muscle contraction and volitional muscle contraction too. Glutamate is an excitatory neurotransmitter that is used widely through the central nervous system. Excessive glutamate release is thought to contribute to neuron destruction after the injury of the central nervous system. So if you remember on the upper motor neuron side, glutamate is that neurotransmitter that's released when there's damage to an upper motor neuron. And glutamate, unfortunately, continues to promote destruction of those neurons to help clean it out, and that can cause further injury. And so that's why when there's damage to the central nervous system, one of the best things to do to try to prevent furthering of that damage is to cool the area. So if you think about spinal cord injury patients who are treated with hypothermia, because they're reducing blood flow to the area so that we're reducing the amount of glutamate that can be produced and causing continued damage, trying to minimize what damage has occurred to that spinal cord. Then we've got aminobutyric acid, which is a major inhibitory neurotransmitter of the brain. Glycine is also a major inhibitory neurotransmitter, but glycine works for the spinal cord. Dopamine influences motor activity, motivation, general arousal, and cognition, and is an important factor in patients with Parkinson's disease. They have decreased dopamine production, which results in a lot of the Parkinson's presentations. Serotonin plays a role in mood, behavior, and inhibits pain, and norepinephrine is responsible in our fight or flight response. Just as important as it is to know what things do within the central nervous system, is also important to know where they are. And so anatomic components of the central nervous system include supportive and protective structures. So we've got the dura mater, arachnoid mater, and pia mater that surround the brain. I would be familiar with the layers and what order they go in. And then between those, we have different spaces. So our epidural space is between the dura and the skull. Our subdural space is between the dura and the arachnoid. The subarachnoid space is between the arachnoid and the pia mater. And the subarachnoid space is important because it contains the cerebral arteries and cerebrospinal fluid and serves to act as a cushion for head traumas. Lobes of the cerebral cortex are extremely important. There are four main lobes of the brain, and each of them has a different job, and so it's important to know what each of them does so that if there is injury to one area, you know what kind of deficits to expect and therefore what kind of interventions to implore. The frontal lobe contains the primary motor cortex, and it's responsible for voluntary control of complex motor activities. So that's going to be the front of the brain because it's named the frontal lobe. It's pretty easy to know where it is, and that's where all of our motor movement comes from. But we also know that the frontal lobe has a strong influence over cognitive functions such as judgment, attention, awareness, abstract thinking, mood, and aggression. And we know this because of a guy named Phineas Gage who got a railroad rod through his head, through his frontal lobe, and he didn't die. They were able to extract it, but he had frontal lobe damage and had all of this aggression and poor planning and inattention that wasn't present before, and so that's how we learned what the frontal lobe does. It's also important to note that the frontal lobe houses the principal motor region for speech, known as Broca's area, and so patients who have difficulty formulating words to be able to speak will often be a result of damage to the frontal lobe. The parietal lobe sits just behind the frontal lobe, and it contains the primary somatosensory cortex. So the central sulcus divides the frontal lobe and the parietal lobe at the top of the brain. And the motor portion sits in front of the central sulcus, and the sensory portion sits just behind the central sulcus in the parietal lobe. This part of the brain interprets incoming sensory information, processes it, and gives it meaning. And then it also contributes to perceptual learning. So being able to process our sensory input in the parietal lobe is how we put context to our learning. And so without a properly functioning parietal lobe, patients will demonstrate difficulty with perceptual learning, especially as it relates to functional tasks. The temporal lobe sits below the frontal and parietal lobes and contains the primary auditory cortex, which helps to decode pitch and volume of sounds, which are then processed in other cortical areas. And so damage to different parts of the brain will have typical presentations, but this is an important note to highlight as far as the brain isn't a segmented structure, and so there's constant communication between all of the sections, and so we can see slight variations in these presentations. Wernicke's area, which ascribes meaning to particular sounds such as speech, is located in the temporal lobe, and so a patient who has difficulty understanding speech will likely have damage to the temporal lobe. It's involved in declarative memory function since it houses the amygdala and the hippocampus. The occipital lobe sits all the way at the back of the brain, just above the cerebellum, and it contains the primary visual cortex, which helps to distinguish fine details of an image that is then processed in the visual association cortex, which spans between the occipital and the temporal lobes to determine an object's identity. So our occipital lobe actually sees things, but it's the communication between our occipital and our temporal lobe that gives meaning or identity to what we are seeing. Our cerebral cortex, so we've got a primary cortex and an association cortex. Our primary cortices deal with granular details, whereas our association cortices create meaning from these details. And so that's kind of where we were just talking about with being able to see something versus being able to apply meaning to it. And so those connections between the different cortices are what give context and meaning to these sensory inputs or whatever other information our brain is receiving. Association areas are responsible for all higher order functions of the central nervous system, including personality, intelligence, memory, and consciousness. Motor areas of the cerebral cortex. So the primary motor cortex is primarily responsible for contralateral voluntary control of the upper and lower extremity and facial movements. So it's important to remember that the left primary motor cortex controls the right side of my body. The right primary motor cortex controls the left side of my body. Neurons in the primary motor cortex do control specific body parts, but they do not map to specific muscles. And so we will take a look at the homunculus that shows the regions for the body that are mapped by the different areas of the brain. The premotor area is involved in well-patterned bilateral movements and appears to direct our movements based more on external cues. And the supplementary motor area is involved with eye control and appears to create sequences of movement based on internal cues. Our brain has two hemispheres, a right and a left, and a person's dominant hemisphere is the side that their language center lies on. So in most people, this is on the left side of their brain, and the dominant hemisphere is typically responsible for verbal, analytic, and language skills. So when we think of left brain function, we think of analytic thought, logic, language, reasoning, science and math, written, number skills, right hand control. Patients with damage to the dominant hemisphere may present with apraxia, which is difficulty initiating or sequencing tasks, difficulty with speech, which would be aphasia, and perseveration behaviors. When we look at the non-dominant hemisphere, which in most people is going to be the right side, it's the opposite hemisphere and is responsible for those nonverbal, artistic, and spatial awareness skills. So we look at things like art awareness, creativity, imagination, intuition, insight, holistic thought, music awareness, 3D forms, and left-hand control. Patients with damage to the non-dominant hemisphere might present with poor judgment and safety awareness. They typically have unrealistic expectations of their physical performance or denial of their functional limitations, and can often have disturbances of body images. They can also be irritable or lethargic, and so the non-dominant hemisphere tends to affect attitude more. The highest level of motor control comes from the cortex, and below the cortex we have subcortical structures. And looking at those subcortical structures, we have the internal capsule, basal ganglia, and limbic system, which you can see lie below the lobes of the brain. So the internal capsule contains the major projection fibers that run to and from the cerebral cortex to communicate with the subcortical structures. The anterior limb connects the thalamus and the pons. The genu contains cortical motor fibers that project to the brainstem motor nuclei, and the posterior limb contains motor fibers from the frontal cortex that form the corticospinal tract and sensory fibers projecting from the thalamus to the parietal cortex. It also contains visual and auditory fibers projecting from the thalamus to the occipital and temporal lobes. Lesions to the internal capsule typically cause contralateral loss of voluntary movement and conscious somatosensation. The basal ganglia projects to motor regions of the thalamus to regulate posture and muscle tone, as well as volitional and automatic movements. Patients with Parkinson's disease are patients who have damage to the basal ganglia, and remember that dopamine production is involved in Parkinson's as well. The basal ganglia is involved in cognitive functions, particularly reward or drive, because it is stimulated by dopamine. And the loss of dopamine neurons, which interferes with movement initiation, produces symptoms such as bradykinesia, hypokinesia, akinesia, rigidity, or postural instability, which are hallmark signs of Parkinson's disease. Our limbic system is involved in memory and emotion and includes the thalamic and hypothalamic nuclei, the mammillary bodies, the basal forebrain, the anterior cingulate cortex, the insula, the nucleus accumbens, the amygdala, the hippocampus, and the entorhinal cortex. It appears to control memory, pain, pleasure, rage, affection, sexual interest, fear, and sorrow. So I would familiarize yourself with the functions of all of these areas of the brain, starting with the lobes and working into the subcortical structures down to the spinal cord and along as we go. Working down from there, we've got the thalamic complex, which is made up of the thalamus and the hypothalamus. The thalamus is the central relay station for sensory impulses, and is the area where the major sensory tracts and the visual and auditory pathways synapse. Motor output from the basal ganglia and the cerebellum converge at the thalamus, where they are transmitted to the cortex to influence motor output. The hypothalamus is responsible for regulating homeostasis and is primarily involved in automatic functions including the regulation of hunger, thirst, digestion, body temperature, blood pressure, sexual activity, and sleep-wake cycles. The brainstem is made up of the midbrain, the pons, and the medulla, and it controls many functions related to sensation, cranial nerves, heart rate, and respiration. Our brainstem is not responsible for things that we have a lot of automatic control over, and so damage to the brainstem is typically life-threatening. The cerebellum controls balance and muscular movements. It is very important for coordination. It's located below the occipital lobe posterior to the brainstem, and damage to the cerebellum is characterized by gait instability, intention tremor, uncoordinated movement, slurred speech, and difficulty with smooth eye movements. It also learns to carry out anticipatory movements that appropriately shift our balance during voluntary movements because of its role that it plays in that balance regulation. And then the spinal cord is important for the coordination of movement patterns and communication of sensory information. It contains local circuits that link sensory and motor pathways to allow for the execution of subconscious reflexes, including withdrawal and stretch reflexes. So our most immediate reflexes lie from innervation in our spinal cord. And so when we think about looking at our DTRs, we looked at that loop going through the spinal cord where our sensory neuron connects to our inner neuron, connecting to our motor neuron to generate the reflex. And so that's how we can make that connection to where our most instinctive or responsive reflexes lie. And on the topic of reflexes, the Babinski sign is one of the most common tests done to assess for damage to the nervous system. So the Babinski sign is one of our subconscious reflexes where you, as the practitioner, stroke the lateral aspect of the foot, and a positive sign is indicated where the great toe extends and the other toes splay out, like in that bottom picture. A normal reflex would be with the toes just curling over in response. A positive Babinski is a normal response in infants, but in adults it's indicative to damage to the corticospinal tract. So all of these cortical and subcortical structures have to communicate together, and then those signals have to relay out to the body on these specific tracts. And so we have our afferent sensory tracts and our efferent motor tracts. And our afferent sensory tracts are made up of our posterior columns and our spinothalamic that we're going to talk about primarily. There are a few other tracts that we may discuss, but the ones that I want you guys to familiarize yourself with most are going to be listed on here. So the posterior columns carry information about position sense, which is going to be our proprioception, vibration, two-point discrimination, and deep touch. And it crosses midline in the medulla. So that's important to pay attention to, especially when we get into spinal cord injuries, because the level of injury indicates whether there's motor or sensory loss and which side of the body that's on. And that's based off of where these tracts cross midline. The spinothalamic tract transmits pain and temperature sensations, and it crosses midline within 3 spinal segments. So you can have patients who have loss of proprioception and deep touch and on one side of the body and loss of pain and temperature on the other side of the body. Part of the anterolateral tract, which conveys crude touch and nociceptive input to the brainstem nuclei to carry out reflexive responses to painful stimuli. Our corticospinal tract is the primary motor pathway and controls skilled movements of the extremities. So when we looked at the Babinski reflex on the last slide that discussed involvement in the corticospinal tract, this is where we're looking at that primary motor pathway. So it crosses midline at the medullospinal junction and has to stimulate lower motor neurons as well as inhibit spinal reflexes. Common indicators of corticospinal tract damage include muscle weakness, paralysis, spasticity, clonus, and the reemergence of primitive reflexes like the Babinski. The rubrospinal tract assists in the correction of movement errors. The lateral vestibulospinal tract assists in postural adjustments through facilitation of proximal extensor muscles. The medial vestibulospinal tract regulates muscle tone in the neck and upper back. The medial reticulospinal tract facilitates limb extensors and inhibits flexors. The lateral reticulospinal tract facilitates flexors and inhibits extensors. The tectospinal tract provides for orientation of the head toward a sound or moving object. Looking at where these tracts run, we can see our dorsal columns with our deep touch, proprioception, and vibration are more on the posterior aspect of the spinal cord, with our spinothalamic tract with pain and temperature and light touch on more of the anterior aspect of the spinal cord. When we're looking at motor function, our lateral corticospinal tract is more posteriorly located than our ventral corticospinal tract. And again, this is going to come into play when we talk about spinal cord injuries a little bit later in the semester. Quick review, because we've touched on this, the peripheral nervous system breaks down into the somatic nervous system and the autonomic nervous system. Somatic nervous system is concerned with conscious reactions to external stimuli and is responsible for skeletal muscle contraction by way of 9 cranial nerves and 31 pairs of spinal nerves. I would review your cranial nerves before your first exam. The autonomic nervous system is an involuntary system that innervates glands, smooth muscle, and the myocardium with the primary function to maintain homeostasis. Specific functions include regulation of digestion, circulation, and cardiac muscle contraction. The parasympathetic maintains homeostasis. The sympathetic is your fight or flight response. The somatic nervous system, quick review of your cranial nerves. Again, I would review these and remember them. Your cervical plexus is formed from C1 to C4, primarily innervates the deep muscles of the neck, the superficial anterior neck muscles, and the levator scapula, with portions of the trap and SCM. The phrenic nerve comes from the cervical plexus, which innervates the diaphragm. And so remembering C3, C4, C5 to stay alive, that's going to be the primary levels of innervation of the phrenic nerve going to the diaphragm, and so makes sense for that to be a part of your cervical plexus. Your brachial plexus, everybody should fondly remember as being made up from C5 to T1 to provide muscles with motor and sensory innervation to the upper extremity. Our 5 primary nerves are the musculocutaneous, axillary, radial, median, and ulnar. Your lumbosacral plexus is L1 to S3 and innervates muscles of the thigh, lower leg, and foot. The 6 primary nerves of that are going to include your obturator, femoral, superior gluteal, inferior gluteal, common peroneal, and tibial nerves. The sciatic nerve is composed of common peroneal and tibial nerves encased in a sheath, innervates the hamstrings, causes hip extension, knee flexion. The reason I bold this is because sciatic nerve is probably the one that patients are going to be most commonly familiar with, and so you want to make sure that you are more familiar with it so that you can be the most educated in the room. Cerebral circulation becomes really important when we start looking at patients following a CVA, and because if you know what artery was involved, you're going to know what areas of the brain are involved, and therefore you're going to know what kind of deficits they're likely to present with. So our anterior circulation is originally supplied by the carotid arteries. We have an anterior cerebral artery and a middle cerebral artery that branch off from that. The anterior cerebral artery, or your ACA, supplies the superior border of the frontal and parietal lobes. The MCA is the largest of the cerebral arteries. It's the most often occluded and supplies the lateral surface of the brain and the deep portions of the frontal and parietal lobes. The posterior circulation comes from your vertebral arteries, which supply blood to the brainstem and the cerebellum, and then branch off into the posterior artery. The posterior artery supplies the structures of the midbrain, occipital lobe, and temporal lobe, and all of these arteries connect to create what's called the circle of Willis. We're going to see different reactions to injury in the central nervous system versus the peripheral nervous system. Lack of blood flow in the central nervous system causes tissue death within minutes because of insufficient glucose and insufficient oxygen. So artery obstruction causes cell and tissue death within minutes, and why time is such an important concept related to CVAs and spinal cord injuries, because that's central nervous system involvement. The excessive release of the excitatory neurotransmitter glutamate places the postsynaptic targets of these neurons at risk of apoptosis, which is spontaneous cell death. The peripheral nervous system injury can happen as a result of stretching, laceration, compression, traction, disease, chemical toxicity, and nutritional deficits. The Schwann cells contribute to nerve regeneration within the peripheral nervous system, but remember those Schwann cells don't exist in the central nervous system. Axons degenerate distal to the site of injury, so from the site of injury, moving distally. That's how they will degenerate. And regrowth happens at about 1 millimeter per day. Findings in patients with peripheral nervous system injury include paresthesia, sensory loss, and muscle weakness. Neuroplasticity is really one of the foundational concepts of physical therapy in the neuro rehab realm, because without neuroplasticity, we really wouldn't be able to achieve anything as therapists. So neuroplasticity is the nervous system's ability to rewire itself and promote and restore function. So the brain can modify parts of itself to serve different functions. It can change the strength between synapses based off of what areas of the brain are being used and what physiological demands are being placed, and it can promote the growth of new axons to create new connections to de-innervated parts of the body. So all of these things happen as a result of the demands placed on the body and the nervous system's attempt to respond. And so what we know with neuroplasticity is that the better challenge that you give to a patient earlier on, the better neuroplasticity that can develop and the better recovery. And so we want to appropriately stress patients following a neurologic condition, because we want to make sure they're not fatigue resistant, but we also don't want to minimize how much we are pushing them so that we maximize the neuroplastic benefits. Moving on to Chapter 3, Motor Control and Motor Learning. Some of this will be a little bit of a refresher. Some of it we're going to dive a little bit deeper into. So motor control is the ability to maintain and change posture and movement. A result of complex set of neurologic and mechanical processes, including motor, cognitive, and perceptual development, have to occur for motor control. It occurs in a cephalocaudal direction, proximal to distal. So that means that motor control develops from head to toe, trunk to tip. And so we're going to require neck control before we can have good trunk control, and we need to have shoulder control before we can have good hand control. And these things are true in the developmental sequence of life as well as the developmental sequence of restoring function. Motor control allows the nervous system to direct what muscles should be used, in what order, and how quickly to solve a movement problem. These things happen in a fraction of a second, so milliseconds are involved in motor control. People with neurologic dysfunction may exhibit the correct movement pattern, but they have impaired timing, so they produce the movement too slowly for it to be functional, or they have impaired sequencing of the muscle contraction, so they produce a contraction at the wrong time. A sensory stimulus produces a reflexive motor response. Sensory input is needed for the mover to learn about moving and the result of moving. And so this factors into, with our pediatric population, why sensory input is so important in motor development, because without sensory stimuli, there's nothing to promote the need to move. And this stimulation also contributes to perceptual development. So feedback provides a means to understand, to process of self-control or motor control. We have two different types of feedback: intrinsic feedback and extrinsic or augmented feedback. Intrinsic feedback comes from any sensory source inside the body, including visual feedback perceived by the individual, such as using a mirror, or tactile, using their other extremity to move one extremity. Any kind of self-perceived sensory information is going to be intrinsic feedback. Extrinsic or augmented is extra information given to the mover by some external source. So that can be the therapist, that can be a biofeedback machine, that can be another patient in the clinic, but it's something outside of the patient themselves. The highest level of many motor hierarchies is volitional or self-control function, and these things are controlled by the cortex of the brain. So thinking about that hierarchy where the highest level of control comes from the highest level of the brain, we can take a look at the reflex model. So one way in which the nervous system maturation has been routinely gauged is by the assessment of reflexes. So the spinal cord is responsible for the simplest primitive reflex, like we talked about, that quickest initiation, such as how we see with DTRs. Tonic reflexes are associated with the brainstem of the central nervous system, and they produce changes in muscle tone and posture. So there's different types of reflexes that we're going to be talking about as we progress through neuro here. Looking at our primitive reflexes. So these are things that we are born with, or they start while we are in the womb. and they should integrate. And what it means to integrate is that they go away. They no longer present as a normal response. But until the age of integration, these reflexes are normal responses. And so these are ones that we're going to want to be familiar with our pediatric population when we're looking at developmental age. Are they presenting with the reflex at the age that they are supposed to, or has that reflex been delayed, or has its integration been delayed? And is that affecting the child's ability to contribute to motor movement and motor planning? And so we'll talk about that a little bit more in chapters 4 and 5. But these are important to know and understand and know the timeline of. So the suck-swallow reflex is going to start at 28 weeks of gestation, so in the womb, and it should be integrated around 2 to 5 months. So that one should no longer be present after 2 to 5 months. The rooting reflex starts at 28 weeks of gestation, and around 3 months should be integrated, shouldn't be present anymore. The flexor withdrawal is, again, 28 weeks of gestation onset with 1 to 2 month integration. Crossed extension is going to be 28 weeks gestation, 1 to 2 months for integration. The Neuro response is going to be 28 weeks gestation with a 4 to 6 month integration. The plantar grasp is going to be 28 weeks gestation, 9 months integration. Positive support comes on a little bit later, so that's 35 weeks of gestation, but integrates very quickly at 1 to 2 months. The ATNR is going to onset at birth and integrates at 4 to 6 months. The palmar grasp is going to onset at birth and integrates at 9 months, and so that contributes to a child's ability to let go of objects. The STNR doesn't start until about 4 to 6 months, and then should integrate when the child is between 8 to 12 months. And the tonic labyrinthine reflex onsets at birth and integrates at 4 to 6 months. And again, we'll talk about these a little bit more in chapters 4 and 5. So our stages of motor control, we need to start with just the ability to move. Then we need the ability to move while stable. Then we need the ability to control that movement. So stability talks about that single segment. Controlled mobility talks about stability of the whole body. And then skill is putting it to a functional task. So stage 1 mobility refers to the availability of range of motion to assume a posture and the presence of sufficient motor unit activity to initiate a movement. Movements lack purpose and are often reflex-based in stage 1. Stage 2 stability is the ability to maintain a steady position in a weight-bearing anti-gravity posture, also called static postural control. So can we move a segment with stability, or can we maintain the trunk in a stable position? Controlled mobility is mobility superimposed on previously developed postural stability by moving within a dynamic posture. So we look at this as dynamic postural control. With trunk control, it occurs when the limbs are weight-bearing and the body moves. And then we take it to the skill is when mobility is superimposed on stability in a non-weight-bearing position. So we talk about things like gait, where there's a period of non-weight-bearing. Even though it's one extremity at a time, we still have that period of non-weight-bearing, and so that's where we take it to a skill phase. With trunk control, it occurs when the proximal segments stabilize while the distal segments are free to move. For the development of postural control, we need certain reactions. And the order in which we develop these reactions is not the order in which we use them for balance, because that can have some variation. But we develop them in the order of righting reactions, followed by protective reactions, followed by equilibrium reactions being the last to develop. Righting reactions are responsible for orienting the head in space and keeping the eyes and mouth horizontal. They're involved in head and trunk movements to maintain or regain orientation or alignment. Their purpose is to maintain the correct orientation of the head and body in relation to the ground, and they have their maximal influence on posture and movement between 10 and 12 months of age in typical development, because there isn't the development of the other reactions yet. Our protective reactions are extremity movements that occur in response to a rapid displacement of the body by a diagonal or horizontal force. The patient needs to be able to bear weight on extended arms to exhibit a protective extension, so prone on elbows and prone propping positions are helpful for promoting the development of the protective reactions. Equilibrium responses again develop last, and they allow the body as a whole to adapt to slow changes in relationship to the center of mass within the base of support. We add extremity responses to the head and trunk movements to maintain equilibrium. We typically first develop these in prone and then supine, then sitting, then quadruped, and last in standing, which is going to be, again, our developmental sequence where we move from prone, supine, sitting, quadruped, standing. Our writing and equilibrium reactions have an age of onset, much like the reflexes do, and they also have an age of integration. However, most of our reactions persist through life in order to contribute to our balance response. And so I'm not going to read through all of these because I think you guys are capable of doing that. But it is important to understand that as the reaction type matures, obviously the ages progress, but its likelihood of persistence also progresses. So we can see that equilibrium reactions have a greater contribution to our maintenance of balance as we age than our head writing reactions. And these are going to be important ones to test and assess for in the pediatric population, again, looking at developmental delays or developmental progress. When we look at our components of postural control, we obviously need to consider our limits of stability. How far can they reach without having to change the base of support to maintain balance? And so that's what we mean when we talk about limits of stability. The sensory organization, how do they make sense of sensory information? Does their brain process it? Are they able to perceive it? All those things. Eye head stabilization, looking at the vestibular function, are they able to understand what an upright position is supposed to look like? Musculoskeletal system, do they have appropriate firing and appropriate strength needed to maintain the postural control that we're asking them to maintain? Motor coordination, are they able to fire the proper motor units at the proper time to maintain that coordinated postural control? Predictive central set, do they have any kind of system inside of them that helps them to anticipate postural changes? Do they have any kind of experience to draw from? Are they learning any kind of muscle memory? What predictive central set is the patient operating with? And environmental adaptations, how well are they able to adapt to their environment, but also what adaptations need to happen within their environment to maximize their postural control? Quick review, the stages of motor learning. We have our cognitive, associative, and autonomous stages. Cognitive, the learner consciously has to consider the goal of the task to be completed and recognize the features of the environment to which the movement must conform. Associative, the learner has developed a general movement pattern necessary to perform the task and is ready to refine and improve the performance of the skill. And then autonomous, the learner does not need to focus their attention on the motor skill and the skill becomes more automatic. Our stages of motor learning become far more important in the neurologic population because they are typically progressing at a lower level or starting their progression from a lower level in that cognitive stage, trying to piece back more items together to create the movement that they have lost. And so it's important to be very mindful in the cues that you're having to give your patient and the expectation that you are setting and the possible psychological implications of what stage of motor learning the patient is in. The effects of practice are obviously that practice helps. The more we practice, the better off we are. But more importantly than that, the how, where, what, and when of all of those practice sessions come into effect of giving the patient the best benefit. So the more closely the practice environment resembles the actual environment that the patient's going to be performing a task in, the better the transfer of learning will be. So when we are giving patients tasks in the clinic that are set in order to mimic a functional task, we want to set up the environment that they're performing it in to mimic that actual functional environment as best we can. We want to consider the stage of motor learning before we increase environmental challenges, but we do know that having patients practice in a setup that most mimics their setup to perform outside of the clinic is going to get the best carryover. When we look at mass practice versus distributed practice, mass practice has greater practice time than rest time. Distributed practice has greater rest time than practice time. And so depending on your patient's fatigue tolerance is going to factor into what type of practice you utilize with mass versus distributed. When we look at blocked versus random, blocked occurs when the same task is repeated several times in a row, and random practice occurs when a variety of tasks are practiced in a random order with any one skill rarely practiced 2 times in a row. And so again, thinking about cognitive level, what the neurological deficit is, and level of frustration that the inactivity may cause a patient, we're going to help guide and select what type of practice we utilize for them. Variable practice occurs when the learner practices several variations of a motor skill during a practice session and is useful in helping the learner generalize a motor skill over a wide variety of environmental settings and conditions. So with that note, we want to pay attention to not having every exercise performance be identical, but adding a little bit of variation to, yes, mimic what their needs are outside of the clinic, but also can their body respond to any change and challenge, and have we provided their motor system the skills needed to do that. A task can be practiced as a complete action, which is whole task, or broken down into its component parts, such as part task. And so depending on what the patient's needs are, we look at whole practice versus part task practice. Typically, we're going to start with more of a part task and help a patient build it together into that whole task. And then when we select the task performance, we can look at the difference between open tasks and closed tasks. Open tasks are those done in environments that change over time. Closed tasks are skills that have set parameters and stay the same. So again, looking at our stages of motor learning, a patient more in the cognitive stage of learning is going to require closed tasks. We need a closed environment, a closed skill set, something where the demands aren't going to change on them so that they can get a better grasp of what those demands are. As they progress, we want to progress them to more open tasks to incorporate that variable practice so that they are better able to respond to environmental demands and challenges outside of the clinic. Open tasks require the mover to constantly update movements and pay attention to the incoming information, and so we do need to pay attention to how this overstimulates our neurologic patients, because they're having to synthesize too much information in order to perform the motor task. We can have either breakdown in task performance or psychological implications.